Morning, everybody. I think it's 10:15, so I think we're going to get started. My name is Olivia Simon. I work with the Ohio AAP. Thank you all for joining us this morning for the diagnosis and management of emergent GI issues, treatment plans, and connecting PCPs with GI subspecialists. A couple of reminders before I throw it off to our speakers. Please remember to use the chat box to share any feedback and ask questions. And when you are entering a message, make sure that you are entering a comment to everyone and not just the panelists so we can all see it. Sorry. CME MOC credit is available today. I'll put the link to claim that in the chat box. CME certificates will be emailed to the address provided, and all credit will be provided by or on November 12th. And also slides and recordings will be available today or be available after today. I'll also provide the link for that in the chat box. Thank you so much, Dr. Adams and Dr. Gelati today. For that, I'll pass it off to Dr. Adams.
Hi, good morning. Thank you, everybody, for joining us today. I want to especially thank Olivia as our manager today and host of the meeting. And we really want to make this talk this morning very interactive. You know, I'm very honored to have Dr. Gelati joining me this morning. And the two of us really want you to interject, ask questions, and you need to do it through the chat, but we'll be monitoring the chat throughout the whole presentation. So please, please let us know if you have questions. You're not interrupting us. We really, really want this to be interactive. So I am Sarah Adams, and I'm a primary care pediatrician at Akron Children's Hospital. And I've been in practice for about 25 years. I really like incorporating, you know, my real life experiences into my practice as a parent, but my joy has really been in speaking to all of you and advocating for children's health. I also am the director of the Ohio AAP's Parenting in Mealtime Playtime program, which is very near and dear to my heart, promoting nutrition and physical activity. So our objectives today, we're going to really talk a lot about abdominal pain and the causes of abdominal pain. And the main, one of the main causes is constipation. So we're going to discuss constipation, but probably most importantly, we're also going to be differentiating between organic problems that are related to abdominal pain with functional. Most of the things that we see in our practice are functional. So we really need to be able to differentiate between the two and also be able to know when is it time to see the specialist. When I was reviewing all of this with Dr. Gelati, we both agreed we're all so busy. So we need to figure out how to do this in a very timely manner and utilize our specialists when it is really necessary. But we don't want to miss those signs and symptoms either. And I think that's what makes it so challenging as a primary care provider. So we're going to go over the common GI office visits that we see as a primary care doctor, including abdominal pain, constipation, and reflux. And we're going to talk about when to refer to a gastroenterologist. And then the majority of our time we're going to spend going over some cases. So common causes, and of course, you know, the list really goes on, but we know constipation, gastrointestinal infections, and other infections. We can't forget others. I know that there have been cases where I've seen kids with strep that the only symptom they had was abdominal pain. Same thing with something like just a viral upper respiratory infection sometimes presents as abdominal pain as well. But there's also mesenteric lymphadenitis, of course, outside of the GI problems like ruptured ovarian cyst. And then don't forget about foreign body ingestion, and then that ever fearful parental complaint, colic. So the list is long. We've got gastrointestinal reasons, and then the non-gastrointestinal reasons. And I'm not going to go and read every single one. I know many of you are very familiar with these, but I'm going to break them down a little bit as well by age. And the reason why I'm doing this is I think sometimes, and I know as a primary care, especially since I've been doing this for 25 years, is thinking to myself, okay, with their age, what are the most common things that I need to remember are more common at this age versus another age? And especially something like intussusception, for example. And then with the neonate, we very often, most of the time it's functional, and we're going to discuss later in some slides like when to really differentiate between that. But the issue, and especially in that first year or two, is that we don't want to miss anything that is significant or a red flag. Next slide, please. And then I really thought it was interesting when I was typing all these out for you to refer to, to have a reference. Again, I'm not going to read through them. It seems like the older that the kids get, the causes of acute abdominal pain become so much more. And so when they're younger, if you looked at the neonate, had a very short list, and now greater than 5 years has a much longer list. And again, if you review those, you could see some of them are intraintestinal or GI related, and some are outside of the GI scope. Next slide. So what exactly is constipation? We hear that a lot in our practice. It's like a parent will come in and they'll say, oh, my child is constipated, or my baby is constipated. And the first question I ask is, I always say, well, what does that actually mean to you? What does constipation mean to you? But what constipation is by definition is infrequent bowel evacuation. Could be hard or small feces, difficult or painful evacuation of large diameter stools, and then fecal incontinence, whether it's voluntary or involuntary. So I would say, 3 to 5% of office visits are due to constipation. Now, I don't know, I might think that when I read that statistic, I thought to myself, it might be a little bit more. But what we do know is that 95% of them are caused by functional constipation, especially in a healthy child that's a year older. But again, very important to identify organic causes. So what is the normal stooling pattern? We know that in the first day of life, at least 90% of infants on, newborns should pass meconium within 24 hours. After that first day, in the first week, on average, I would say there's like 4 times a day. But remember, babies can go every time they eat. And in some breastfed babies, there can be a delay in that first week because of the waiting for the milk to come in. And so maybe in a breastfed baby, they're only stooling once a day, or maybe skipping a day. Now, I will say though, in that first week, again, it's really important to know when did they pass that first meconium, so that you can kind of gauge, is this something that we should watch, or is there an issue? I would like to remind everybody, when it does come to breastfeeding, yes, it's important to ask about urine output, but really when it comes to that baby, that infant, newborn, neonate in that first couple weeks, the stooling pattern really tells us more of the story if the mom is producing enough breast milk, not to mention the weight. Now, after that, in the first month to 3 months, if they're breastfeeding, they could be, maybe 3 times a day. They could be stooling at least with every feed, or it could just be once a week. If they're formula feeding, on average, it's usually twice a day. If they're on and then it depends on the formula. So if they're on an, alternate formula like soy for any reason, like galactosemia, the stools could be a little bit harder and a little less frequent. But if they're on a hydrolyzed formula, for example, the stools could be more frequent and looser, and that's considered normal. Now with toddlers, they usually go anywhere from 1 to 2 a day. And then for children, it could be 1 or more a day. But the big thing that we really want to follow is what is the transit time? Like, what is the time that it takes between and to stool? Because that could be a measure of a concern for motility. So causes, like I mentioned, 95% of the causes for constipation are functional. It's very common in preschool. It's present in at least 2 out of 6 criteria described, with stool frequency, their hardness, their size. They may present with fecal incontinence or stool retention. But again, it's very important to exclude those organic causes, which are about 5% of the cases, most often seen in young. And the next table, go ahead, has a table that really kind of diagnoses what exactly is functional constipation. And so, and there's other resources for this too, but I think the point of the matter is to remind ourselves what is normal and what is something that we can manage versus something that we need to refer. And the other thing is that we do have to be sensitive, because even though we might say to a family, oh yeah, that's totally normal, and then move on because we're busy or they have other concerns in our practice, to them, it's a really big deal. And so I always say there's 3 things we can't make a child do. We can't make them eat, sleep, or poop. And when they're doing those things, we feel as parents and as providers that they're doing pretty good. So, pooping is in that top 3, I always say. And so remember that they're very sensitive and concerned about it. So even though, we can tell them that this is functional and that we can help you, but and reassure them, we don't want to, disregard their concerns. Next slide, please. And I am not going to read this. This is just for your reference, but this talks about a number of different causes of constipation, functional and then organic. And we're going to go through some of these in later slides. So how do we exactly evaluate? Well, history is so important, and you can do this pretty quickly. You can ask either the parent or the child if the child is age appropriate. It's kind of funny. They always giggle when you want to talk about their poop. And, a lot of times they're like, I don't know, and many times after they have hit the age where they're, taking care of themselves, wiping themselves, for example, a lot of times parents just have no idea. And they could be presenting with abdominal pain and not even realize that their child only poops once a week, So countless times where they've been shocked to hear that from the child, but very often the child will say, I don't know, especially if they don't go frequently enough. So you want to look for acute signs. Again, in that older age group, delayed passive of meconium. Is there fever? Is there vomiting and diarrhea, especially in the with a history of constipation? Is there also some vomiting and diarrhea? Is there rectal bleeding? And really important is, especially in infancy at really at any age, is do they have abdominal distension? Now, with those little ones, I always joke that God made babies with really big bellies and little teeny butts. And so, you might get a history, their belly is distended, and let that be a red flag. But, most often, really what they're talking about is what looks normal physiologically. Chronic signs, has this been going on since infancy or very early age, especially newborns? Do they have those ribbon stools we've all heard about? Ask them about their weight, their growth, and are there extraintestinal signs? What is there any anorectal concerns and congenital anomalies, and especially family history such as Hirschsprung's? I don't know about you, but I hear the word, my baby is straining. And so this is called infant dyschezia. And the most important thing to remember is, are they straining and they have a soft stool, or are they straining and they have hard stools? And so this is very, very important. It doesn't mean if they say that they're straining and they have soft stools that you can't continue to investigate, but that kind of gives you a little bit more, feel a little more relaxed. most common in young infants, we want to look for signs of Hirschsprung's and CF or ask about those as well as and in the family history. Psychosocial and environmental factors. We can't forget about this. Like, when did it start? Are they still withholding? And one of the things is this could be a clear cause if you do treat and they have a good response to treatment. Now, lead intoxication is very important too, especially if you have a special needs or developmentally delayed child, and pica is a concern. So don't forget about that. And important to also ask in history is if another sibling has ever had an elevated lead, especially if you're dealing with an infant, or, you know, what is their home environment like? And or work, you know, their parents' work environment. And then developmental history, looking for history of mitochondrial or neurologic, and medical history, of course, is very important too for the child. Next slide. So these are, we talked about straining. So I kind of want to go back to that. And this breaks it down to kind of like, what exactly are the clinical characteristics when an infant is straining? So soft stools are passed after they've been straining versus hard stools or larger pellet-like. Anal fissures, you know, looking for anal fissures, which can be a sign, could be voluntary stool holding. And honestly, because I don't know about you, but kids are really good at not doing what they don't want to do. And if it's painful, they're certainly not, if they can hold it, they're going to, because they don't want to have pain, which I don't blame them, you know. Cow's milk intolerance, and then of course, Hirschsprung's. And, you know, when we look at the clinical characteristics, newborn or infant, delayed passing of meconium and after the first 48 hours of life, they could be well or ill appearing, remember, that abdominal distension, the occasional diarrhea, and then doing that rectal exam. And then if needed, then referral for anorectal manometry. Internal and sphincter achalasia too, again, is something that we would be watching for and would be consideration for referral. Next slide. So again, general evaluation, look at the neurologic signs, check the perineum. You know, I have to tell you, one time I didn't see the baby in the newborn period or the 1 week follow-up, but I saw the baby at 3 weeks, and the baby was having infrequent stools, but when it did have a stool, it was very liquidy and there was some blood. And when I looked at the perineum and the rectum, I realized that really what I was looking at was a fissure, and that this child actually had imperforate anus. And so, you know, she passed meconium, some stools, she was stooling. And so I could understand why it was easily missed. But I just remember, I'll never forget, you know, looking and thinking, that doesn't look normal to me. So don't forget to look. It's very important. I've made it part of my routine physical exam. I'm sure you do too. And then other things like, you know, so the digital rectal exam. Now I'm going to tell you, it doesn't necessarily have to be routine. You know, there are certain reasons, you know, that you would want to do a digital rectal exam, but it's not routine, at least for the primary care provider. And then suggesting functional constipation could be distended rectum that's full of stools, but the lack of stool doesn't necessarily mean that they don't have functional constipation. And then of course, testing for occult blood, whether it's from a digital exam or from the diaper. So testing is always interesting in my thoughts. And that is that, like, for example, even though I list abdominal radiographs, it really isn't necessary to do an abdominal radiograph for every child, you know, that comes in for constipation. So just remember that, you know, how important that is. When it comes to like a barium enema or spine radiograph, you know, on our physical exam, we do want to be looking for any kind of weakness. For example, we were talking about neurologic exam, and you do want to inspect the spine. Now, if it gets to a point where it's a barium enema or spine radiograph, then, you know, I would leave that to the decision of the gastroenterologist. As far as labs go, you know, I mentioned on there urinalysis and urine culture. Remember the relationship between having that pressure on the bladder. And so looking for any signs and symptoms of a urinary tract infection, electrolytes and calcium, especially if they're having dietary concerns and weight loss. We know hypothyroidism can be a cause for organic constipation, and then also checking blood levels. Next slide. So when to refer. And, you know, if you're doing the common things that we do to treat, then I think it's important, and you've changed diet and you've done some lifestyle, and we're going to talk a little bit about that, then it's time to refer. If there's significant abdominal distension or any sign of obstruction, if you do suspect Hirschsprung's, absolutely. If there's persistent hematochezia, and we're going to go through those in some of our cases today, poor growth, poor weight gain, and if there's an abnormal physical exam. So treatment, you know, very often infants can respond to non-digestible osmotic activity carbohydrates, which basically we're talking about juice. You know, they usually do respond to juice. And then there's the pharmacotherapy such as lactulose and polyethylene glycol. Glycerin suppositories really should be you know, held for if you're concerned about like impaction or very, very infrequently. I always try to tell parents, like, work from above before we work from below. For children, disimpaction, and especially if there's fecal incontinence and a large rectal stool mass, and then, but probably the most important thing that I want to say today is prolonged laxative treatment and behavior therapy. Together, they work better. Now, prolonged, and what I mean by that is really like, we see a lot of recurrence in our practice, because what happens is they get better, they want to stop the medicine, or their stools get loose, and then all of a sudden they don't want to, you know, they stop the medication, they come back like 3, 4, maybe 6 months later, and they've got the problem again. So it's very important that we discuss like and set up a really good treatment plan for them, and then gradually taper it as they tolerate it. Next slide, please. So this is just one example of exactly how to treat for you know, constipation, whether it's recurrent or chronic. And the key here is basically this: you want to first get the stools complete, like very soft, and they should be going at least once a day. So maybe even on bordering on loose, and Dr. Galati can kind of reiterate that for us. But before you decrease it, okay? And then after you get to once you've got the stools are soft and they're going and they're not withholding, then you can start gradually decreasing it. And then there should be a follow-up, you know, whether it's a phone call or whether they come back into the office. Follow-up is so important. I kind of attribute it to like dealing with children with mental health. We don't know what we don't know. And so it's really important that we follow up and make sure that this regimen is working for them and that they really understand what they're supposed to do. And then you continue to add dietary fiber. You want them to like continue for at least like 6 to 8 weeks until they've got a very soft daily regimen, and then taper very slowly. And honestly, this could take months, but that's the key. And it's very, very important. I always try to say, choose your hard. You know, do you want the hard, and no pun intended, But, we want to get them going and going frequently, and at least once a day, or minimum every other day. And we want it to be soft. And then you can just slowly taper it off so that it's easier next as time goes on. Next slide. Behavior modification, though, is very, very important. It's almost like the treatment to soften the stools are like a Band-Aid, but at some point we do have to take that Band-Aid off. And so we want them to know what behavior options they should be trying. So toilet sitting after a meal, 5 to 10 minutes, 2 to 3 times a day. And I tell them, sit with them. Don't make it a punishment, sit with them, read, play music, whatever you need to do. And even if they don't go, really praise them. It's very, very important that we educate our parents about like what this, how to help their kids, not just with treatment medications, but emotionally too. So take out the negativity, help them understand what the developmental and cyclic nature is for their family, and remind them that the behavior modification is just as important as the laxatives, and make sure this recovery is gradual, like I said. So toilet sitting episodes, they should be about the same time and timed, routine, and really, encouraged with positive reinforcement rather than negative reinforcers. And don't forget, if the child can't touch the floor, it could be very difficult for them to stool. So, tell them to get a little stool. Next slide. Okay, so that's what I have on reflux. I don't know if there were any questions, or I'm sorry, on constipation. If there were any questions that we wanted to go over before we talk a little bit about reflux.
There's no questions in the chat box at the moment, so just a reminder, definitely feel free to enter them in there because we can take pauses throughout. But if there's none at this time, I think we can go on to the next section.
So reflux is another thing that I see in my office a lot. And I think what's really important to remember is that there's gastroesophageal reflux, which is, uncomplicated, versus GERD, which is gastroesophageal reflux with disease. And so, very simply, when I talk to families, I mention there's 3 things that we worry about when a child is refluxing. We worry about, like, I don't say esophagitis because a lot of times they don't understand that, but we want to make sure that they're gaining weight. We want to make sure that they're breathing okay. And we want to look at, is there any sign of pain? So again, esophagitis, nutritional compromise, more out than in, and then if there's respiratory complications. So we want to make sure that we can identify those warning signs and symptoms versus a happy spitter. I always tell parents too, look, there's a reason why they sell burp cloths. It's very, very common physiologically for babies to spit up. And usually it resolves by a year of age, but if they're not, improving after 18 to 24 months, definitely further evaluation if it's not already been done at that point. There's things that you can do like thickening feeds, changing position or position therapy, and then even considering changing formulas up to a hypoallergenic diet. There's lifestyle measures too. So breastfeeding as much as you can, they tend to do better versus formula, avoiding tobacco smoke exposure, and overfeeding. So if we have reflux and poor weight gain, then, we really want to make sure, is there any trouble with swallowing or dysphagia? What's the caloric intake? If we did consider an upper GI, basically explain to the families it's just to rule out anatomic abnormalities if necessary. And then pyloric stenosis or pyloric ultrasound to rule out pyloric stenosis if they say that they have projectile and frequent vomiting. Now, it's very tough because I don't know about you, but when I ask them, about vomiting, they know that word projectile. Like you don't even have to say it, and they'll come in and be like, "My child's projectile vomiting," And so, don't be afraid to ask specifically, how and how much they are actually spitting up or throwing up. Consider checking for occult blood. Don't forget to review the newborn screen. So important. Very rare. In my 25 years, it's been very rare that there's one that, that we don't get. But sometimes you'll get a patient who comes from a different office, for example, and getting that newborn screen is very important because you never want to assume that it's normal if you haven't heard from ODH or that a previous physician has reviewed it and it's okay. That's what I always say. So the newborn screen is very important. Thickening the formula if you do suspect GERD, increasing caloric density, and then a trial to reduce gastric acidity if it's necessary. Now, with reflux and feeding refusal, this can be very challenging sometimes, and reflux and irritability, and also reflux and rectal bleeding. Now, I want to remind people, though, that most babies, if they're not sleeping well at night, it most often is not due to reflux. So talk about like sleep disturbances. Reflux or GERD is a very rare cause for sleep problems. Sandifers, do they have that arching and turning and lifting of the chin? And ask about those kinds of things when they are irritable. The timing of their reflux is also extremely important. Next slide, please. Now, there's a higher rate of GERD in prematurity and pulmonary disease, of course, developmental or other disorders like CP, muscular dystrophy, Down syndrome, CF, and obesity. Most often with preschoolers, again, you could get Sandifers and see that in infants, but you can also see it in preschoolers as well. Children and adolescents may actually describe heartburn or regurgitation. And, when you're taking your history, is there that heartburn? Is there chest pain, abdominal pain? Do they regurg? Do they have that water, yucky stuff? When did it start? What's the relationship to meals? Do they have dysphagia, where I see that sometimes where they're like, difficulty with swallowing, or they feel like something stuck in the back of their throat, or odonophagia, which sometimes teenagers, especially that are being treated with acne, will sometimes develop because of what we call pill esophagitis, because they probably didn't take their medicine well with water, and then they get that irritation. And so that's not an uncommon complaint, actually. And so to deal with that, you basically want to tell them to stop the medication, maybe it's doxycycline or minocycline, which tend to be more common, or anti-inflammatories, and then a short treatment with something like sulforaphate or a PPI. And then, of course, if it doesn't improve, then you want to refer. The other things are, again, looking for neurologic dysfunction, congenital anomalies. Do they have asthma, a pneumonia, chronic cough? And really getting a good medication history too, as I mentioned. Next slide. So the general approach is your history, your physical, the differential is wide. You want to look for warning signs like if they have fever, if there's weight loss, if there's distension, bilious vomiting, throwing up blood, hepatosplenomegaly, headache, or other neuroscience. We want to look for gastroparesis, making sure that they're having good gastric emptying, rumination, and psychogenic vomiting. Pregnancy, I don't even want to think about that in my adolescence, but it's definitely something you need to think about. And don't be afraid to ask about substance use and hyperemesis, because that can absolutely occur. They're definitely not going to tell you unless you ask. For heartburn, a trial of lifestyle changes and or acid suppressing medications. And then that esophageal inflammation, like I said, that pill esophagitis, stop the medication, short treatment with something that will help with their symptoms. And then if that's not helping, refer. Don't forget that asthma very often can be exacerbated from reflux. And so it is suggested to use an acid suppressing medication for around 3 months. So that should be part of your asthma action plan. And then if there's recurrent pneumonia or chronic cough, imaging to look for signs of aspiration, especially those that are neurologically delayed. So when do we refer? Well, if the symptoms go beyond 15 to 18 months, if the child is having feeding difficulties, if they're resistant to treatment, which again should be lifestyle changes as well as medical management, dysphagia, hematemesis, reflux with failure to thrive, and then if there's concern for eosinophilic esophagitis. So I'm going to go ahead and turn this over to Dr. Gulati, which I'm very honored to be sharing this presentation with. And she's going to introduce herself and then continue to talk about what we can do and, kind of continue the talk about things that are common and how to work them up and review cases. So thank you all for listening.
Thank you, Sarah, for that excellent talk. And it was so interesting to kind of step into your shoes and just, feel what you see on your side. And obviously I see these patients as a specialist. So it's good to get into a primary care's world too. Hello, everyone. I am Dr. Gulati. I'm so honored to be here today. Thank you to Ohio AAP for inviting me. And thank you to all my wonderful partners for this great talk, and I'm excited to share my perspective as a specialist. But as Sarah pointed out, I invite you to, keep this interactive format going. Please ask questions when they come to your mind. We have a wonderful moderator here who will bring up these questions from time to time so that we keep answering and engaging with you as we go along the talk.
Dr. Gulati, before we jump in, there is actually a question in the chat. So I might want to, before we get, so I don't interrupt your whole spiel. So
bring it on.
Yeah. I actually might have a hard time pronouncing some of these words, so I'll do my best, but discuss ranitidine and omeprazole long-term. Yeah, omeprazole long-term. And can we use ranitidine? Ranitidine. Sorry, I hope I'm not missing.
Oh, that's a great question. So I think this question is from Ellen. So Ellen, I believe, and I'm quite confident that ranitidine is not back yet on the shelf to be used. It is an H2 blocker, but we have famotidine, which is popularly known as Pepcid, and that can definitely be used even for the long term. There are almost minimal to no side effects with even long-term use, which we see in many of our chronic reflux patients, as well as our special needs kids, especially cerebral palsy kids who have chronic GI dysmotility issues. But ranitidine, I believe, is not back on the shelf yet. It was withdrawn from the market not because of the medicine itself, but because of an additive. And there was a concern that that additive is a carcinogenic agent. I have not prescribed ranitidine since it was withdrawn from the market. It may come back. It's as I said, not related to the medicine itself, but an additive in the formulation. And omeprazole, which is popularly known as Prilosec, is a proton pump inhibitor. So this is a class of medicine that is known to be the strongest acid suppressant. It blocks the final common pathway in acid production. It is also safe even for long-term use. However, again, because it is such a strong acid reducing medicine, we want to make sure that we constantly reevaluate its usefulness in an individual patient. And as a practical step, I try to step down my patients as much as possible to an H2 blocker once their acute reflux phase has been controlled. Yet again, in some cases of severe erosive esophagitis, or if someone has Barrett's, which is very uncommon in pediatrics, but not unheard of. I have personally taken care of some adolescents with Barrett's esophagus. PPI is the way to go. PPI therapy, meaning medicines like omeprazole, lansoprazole, esomeprazole, and all these azoles. Yeah.
Thank you.
So there's a question from Ailing. I have seen more GI physicians use famotidine for infant GERD. Yes, it is safe for use even in infants. The point being, however, that we should be using it for the right reasons, meaning we all are probably familiar with the pervasive issue of overuse of acid reducing medicines in infant GERD. And as Sarah had talked about, when we are evaluating an infant for GERD symptoms, we really need to focus on determining if this infant is what we call as a happy spitter versus is this GER, which is gastroesophageal reflux, plus the D, which makes it GERD. And the D stands for the disease part, or an issue in addition to the regurgitation, which would then take them out of the happy spitter category. And those are the patients that may benefit from acid reducing medication. And I always, I cannot emphasize enough the point that, and I share this with my patients and my parents also, that the purpose of using acid reducing medication when we are treating infant GERD is not to stop the physical regurgitation. We may or may not be able to affect it because that depends on the tone of the LES, which is the lower esophageal sphincter. The primary purpose is to reduce the irritability, the Sandifer type symptoms that we were hearing earlier. That is the purpose of use of medication. So I think that expectation needs to be set very clear with the patient, that the usefulness of this medicine is because, the biggest concern is, significant irritability. This is a baby who can't stop crying or who's irritable. And, there's evidence that the acid may be burning, in burning, meaning like causing acid burn in the esophagus. And obviously, happy spitters, there is no benefit from the use of medications in the happy spitter category. And then Sherry asked, that's a great question, Sherry. Again, if I feel that it's appropriate to prescribe an acid reducing medicine, which again is mainly used to treat the irritability coming from GERD, although it may or may not affect the actual regurgitation or the amount or the frequency, I tend to go higher. I use 1 milligram per kilogram per day to 1 milligram per kilogram twice a day. But you can start with 0.5 milligram per kilogram per day and go to as high as 2 milligram per kilogram per day divided BID. Okay. So I think those were the questions so far. I think we can move on, Olivia. Perfect. Okay, so the part of the presentation that I'm going to focus on now, and again, I invite you all to make it as interactive as possible, are these clinical vignettes, these cases that we see quite commonly in primary care as well as specialist offices. And any of us could be dealing with this in our individual workplaces. And so the goals of the goals for these case discussions are to understand the basic principles, identify some of these key words or phrases that can help you think about that thing out of all the possible differentials. We'll discuss some specific disorders, and then the floor is open for discussion. Okay. So going back to Sarah's point, presentation, abdominal pain is probably one of the most common GI complaint that you see in your office. It is a common symptom. And broadly speaking, the causes of abdominal pain can be divided into organic and functional. And this is etiology wise, and there are other ways in which abdominal pain can be classified as acute versus chronic. Chronic abdominal pain has been going on for at least a few months. I know some references talk about 6 months. I think that's still too long. Definitely a few weeks to a few months would be appropriate to classify as chronic. And then red flag symptoms, I call these red herrings or red flags. You can, call it whatever you want, but there are some, clinical characteristics, some signs and symptoms, that suggest a possible organic etiology and will help you differentiate even as you are taking your history and of course then doing your physical exam during your initial evaluation. It will help guide you towards one broad category versus the other. So what are these red flag symptoms? Younger kids, less than 5 years, presenting with acute or chronic abdominal pain, presence of fever, bilious emesis or hematemesis, which is vomiting blood, unexplained weight loss, when the pain is focal and non-periumbilical and not generalized, and referred pain to either shoulder, groin, back, or any other body part from where it starts. If it is referring to some place, then again, chances are that this is a focal cause of abdominal pain, more likely to be related to underlying inflammation of an organ system, or, for example, appendicitis, or a particular organ in the GI tract. Okay, next. Nighttime awakening, so pain that actually wakes you up from sleep, not pain that is felt more when you're going to sleep, when you're less distracted, which you will hear a lot with kids who have functional abdominal pain, when the excitement of the day is over and they're kind of getting ready to sort of go to bed and there's not a lot going on. That's when functional pain can be felt more, just because the noise of the day is over. This is pain. Nighttime awakening is pain which actually wakes you up from sleep. Then, of course, coming to some of the physical exam findings, if you feel a mass per abdomen, that is a red flag. And then there is no what I would say as a fixed list of tests that can be done as you evaluate abdominal pain. It all has to be guided by your history and your physical exam, family history, and history encompasses everything: personal history, family history. So there is no laundry list of, tests that can be done in an individual. It all has to be individualized to the presentation, but most people do this broad screen in which they look for, anemia by checking a CBC. They may check inflammatory markers like ESR or CRP. Then, if there is a reason to check liver functions. So of course, abnormal basic laboratory tests may reflect some underlying abnormalities, although I don't recommend any specific list. It all should be guided from your patient's history and physical exam. But then again, keeping in mind family history, especially of disorders like inflammatory bowel disease, celiac. We go by this, common rule of tens, so if you have a first degree family member with inflammatory bowel disease, you are about 10 times higher risk, lifetime risk of developing IBD, 10 times higher risk of developing celiac. But then again, also remembering that disorders, more functional disorders like reflux, irritable bowel syndrome, constipation also can be familial. Next slide. This is what I was referring to with focal abdominal pain. I'm sure we are all very familiar with this diagram, or have definitely evaluated children, keeping these different organ systems and their locations in mind. So the idea is not to go through this slide, but just as a quick review. Next slide. Okay, so I think we're coming to some of these, what we call as clinical vignettes, some clues, and I appreciate if the audience wants to, put their comments on what this might be, or which condition do we see the corkscrew, sign in. But that's what this radiograph shows. This contrast radiograph is the corkscrew sign, and this represents malrotation and acute a cause of acute abdominal pain, usually presents with intestinal obstruction, seen mostly in kids with previously unknown malrotation problems, but also can happen because of adhesions from prior intestinal or GI surgeries. Next slide, please. So, acute abdomen in infants. Again, this is obviously acute onset, and more often than not, this is because of an organic underlying cause. So if we have an infant who's presenting with bilious vomiting, abdomen is distended, think about malrotation and volvulus, and the diagnostic test of choice is an upper GI, which is what you saw earlier. And malrotation can be diagnosed even prior to, an acute event like this developing in the setting of certain dysmorphisms where malrotation can be a part of a genetic syndrome, or recurrent vomiting in kids. And they look at the relationship of the ligament of Treitz to the spine. That's what radiologists are looking for. And as I mentioned, volvulus on a plain or contrast radiograph will show the corkscrew appearance. Okay. Surgery is the treatment for that. And so this is basically the ligament of Treitz area. And normally it should lie a little bit, midline or to the right. And here it is lying to the left. Okay. Next is the donut sign. So this is an ultrasonographical sign. And any input on what this represents? It's again a cause of acute abdominal pain typically seen in infants and toddlers, very common presentation of intussusception, which presents as acute abdominal pain and with current jelly stools. And this is what you would see is the target sign or the donut sign. Okay, we can move on. So colicky abdominal pain, current jelly stool, suspect intussusception, peak age is 6 months to 2 years. It is the most common abdominal emergency seen in infants less than 2 years. The most common is ileocolic, it is idiopathic. Recognizable lead points, which is where the intussusception is happening. That's what a lead point means, is actually found in less than 10% of the cases. So as I said, it's idiopathic. For the most part. But when you do see it outside these age ranges, you should think about, intestinal anatomical issues like Meckel's diverticulum or duplication cysts. Sometimes even polyps can cause intussusception. Treatment is a reduction, either radiological reduction using an air contrast enema or then surgical reduction. So again, certain disorders associated with intussusception, cystic fibrosis and HSP. On physical exam, you will see this, you may feel this sausage-shaped mass. It is tender, although many times the intussusception, it's a transient, recurrent event. So sometimes the physical exam may be perfectly normal when the patient is presenting to you. The ultrasound will show the target of the donut sign, and we talked about the treatment, which is usually done by interventional radiology or surgery then if needed. Okay, next. I'll take some questions. I'm just going to briefly stop and take some questions. I like Daniel's comment, which says 80% of adults with celiac disease do not know this. So checking for celiac and chronic abdominal pain is never a bad idea. I completely agree with that. In fact, many of you may be familiar with what we call as the celiac iceberg, that iconic picture where really symptomatic celiac is only the tip of the iceberg. There is the big part of the submerged iceberg is actually asymptomatic celiac, where you're completely right that most people do not have any symptoms, or at least may not have the classic symptoms of celiac. So I completely concur with that statement that any patient with chronic abdominal pain, checking celiac is not a bad idea. And then Sarah asked, how often do you see the current jelly stools? I always worry I'm going to miss this. So, I'll be very honest here, Sarah. This is an acute abdominal, presentation. Most of these children present to the ED or the urgent care, not a specialist office like me. I think, again, anecdotally, this is quite common. I would say if I had to put a number, maybe 50 to 60% of the times you will see some changes in the stool, especially if it is, recurrent intussusception. But definitely I can find out what's there in the literature and let you know. But this can be a little tricky. Intussusception can be tricky because, as I said, it can be intermittent. I've seen some cases where it took a few times before somebody thought about it, but of course, it was like this patient was having clusters of abdominal pain, but then would present. And by that time, the abdominal exam would be completely normal. And if you actually do an ultrasound at that time, you may not see the donut sign or the target sign. But I do want to emphasize, I, as a specialist, don't get to see many of these patients in my office because they tend to present in acute settings in the ER and the urgent care. But hey, if you suspect it, again, an ultrasound is a pretty non-invasive quick test available in most places, so go for it. Okay. So next is this clinical vignette. Bilious vomiting. Again, we are still at the infant stage. No abdominal distension. This is a baby with Down syndrome, and you see a double bubble sign on plain radiograph. About half of these babies may be premature. About half of these babies may have Down syndrome, trisomy 21, and there may be a history of polyhydramnios during pregnancy. What are we dealing with? Okay, duodenal atresia, we can move on and talk about that. So this is, a presentation of duodenal atresia, again, an acute abdominal emergency in the first few days of life. And just like any other intestinal obstruction, this is, of course, higher up, upper intestinal obstruction. You will put an NG to decompress. And there's a high likelihood that these babies may have other congenital disorders, some of them even life-threatening, like congenital heart diseases. So definitely evaluate for those. And then the treatment for duodenal atresia itself is duodenodionostomy. So it's a surgical treatment for this condition. Okay. And that's the double bubble sign, the stomach, and then the distended proximal duodenum above the atresia. Moving on to acute abdomen in older children. So bike handlebar injury will present with non-bilious emesis and, of course, abdominal pain. And this is the classic bike handlebar injury is a duodenal hematoma. Okay. Then periumbilical pain. Going on to the right lower quadrant, presence of anorexia, fever, even elevated white count. We all know that. Acute appendicitis. And then blunt trauma to the epigastrium, abdominal pain, vomiting, and a sentinel loop sign on a plain radiograph. Acute pancreatitis. Okay. Can move on. So appendicitis, as we know, is the most common acute abdominal emergency in children. And we all know that not everybody will present with the classic symptoms. So it should be, high on your differential if the onset of pain is acute, especially if associated with significant anorexia, nausea, and the localizing right lower quadrant pain. But again, also being aware that it can initially start periumbilical and then proceed to the right lower quadrant. So sometimes a period of observation, could be helpful. If you suspect it, but there aren't classic symptoms, like right away, either you could resort to imaging or a period of extended observation to see which way this is headed. And if you diagnose appendicitis, again, the treatment is surgical, unless by the time the patient presents to you, the appendix has, bursted, or there's a phlegmon, in which case many times, surgeons will, have an interval period where they will treat with antibiotics and let the, localized peritonitis settle down, and then do an interval appendectomy. But most of the times, acute appendicitis can be taken care of, with an emergent surgery. Okay, next slide. Okay. I think we know enough about appendicitis. We will move on. We have a lot to cover. If there are any questions, of course, if your classic exam is, if your exam is not classic and you're considering imaging, ultrasound is usually the first imaging of choice because it's readily available and it's, does not have the risk of radiation. And if inconclusive and the index of suspicion still remains high, then certainly a CT scan would be useful. Next, we talked about pancreatitis. Most of the first onset pancreatitis cases are idiopathic, meaning not related to any particularly identifiable cause, so presumed viral. There may be a history of fever or sore throat or just URI symptoms, or sometimes not. And it's usually, severe epigastric pain with nausea, vomiting. You check your amylase lipase. Lipase is more specific and it should be elevated at least 3 times upper limit of normal. That's, highly suggestive of pancreatitis. Most of the times, people will add imaging, mainly to rule out like pseudocysts or gallstone pancreatitis or gallstones causing pancreatitis. So an ultrasound is usually pretty commonly performed in the evaluation of pancreatitis, although the diagnosis can be made with the combination of the characteristic clinical symptoms and elevated lipase at least greater than 3 times upper limit of normal for that lab. And then other causes of pancreatitis like trauma, gallstones, we talked about drug toxicity, especially some chemotherapy medications. Next. Of course, we know a lot of drugs can be associated with pancreatitis, but these are some common ones that some of your patients, especially special need kids who are on anti-seizure drugs, and then of course, some chemotherapy medications can also be associated with pancreatitis. And most of these are idiosyncratic reactions. They are not dose dependent. Okay, next. I think we can move on from this. We talked about this. Coming to cholecystitis, again, an increasingly common cause now of abdominal pain in kids, unfortunately, because of the epidemic of obesity, which has increased the prevalence of gallstones in kids. So, earlier we used to, when I think we were all in medical school, we used to talk about the 40s and the fertile female, but I don't think that, holds true anymore. We're seeing more and more cholecystitis in the pediatric age range, presents with fairly classic symptoms, right upper quadrant pain, nausea, vomiting. This can be acute or sometimes it can, be episodic. And usually the diagnosis is made by, it's certainly suspected based on clinical findings and then confirmed by an ultrasound. And then, some other relatively uncommon causes of cholecystitis would be gallstones seen in the setting of hemolytic anemias. And then very, very rare are gallstones seen in the setting of bile acid transport defects, also associated with cholestasis. Okay, shifting gears a little bit here. Some of you may find a patient in your clinic, or if you work in the urgent care, with a foreign body lodged in the upper GI tract. These are some common locations where it can get stuck because of physiological narrowings. And then again, depending on the size, the shape, the sharpness, the bluntness, there are just so many factors that go in triaging how to manage an individual case of a swallowed or foreign body. Okay, next slide. again, this is just a picture highlighting the physiological narrowings in the GI tract where a foreign body can get stuck. Next. I'm sure you probably all have seen some, infant, toddler with an accidentally ingested coins. They are most common because they're all around and they're attractive, and our kids love to experiment by putting things in their mouth, and before they realize, there it goes inside. The most common areas where it can get lodged is the upper GI tract, so upper esophagus, but sometimes also mid and lower esophagus. And as we can imagine that it'll be the coins lodged at the level of the cricopharyngeus, which will probably be the most symptomatic, with a lot of drooling and discomfort. Once they go lower down, they are less symptomatic, but they can still continue to cause chest pain symptoms. And in general, no foreign body, regardless of bluntness or sharpness or corrosive potential, no foreign body should be left in the esophagus for longer than 24 hours. So if we have a foreign body in the esophagus, more likely than not, it will require removal. And we have a 12 to 24 hour window, again, depending on what the foreign body is. So here is where you will need to call, your trusted GI partner to come and help out. Next. Now, even with coins, about a quarter of those that are ingested that may initially be in the esophagus can actually pass spontaneously. In fact, because we do have a window for coins since they are, blunt. And if the kid is not symptomatic, meaning not acutely drooling, able to manage their airway, we can wait a little bit, especially if the coin is in the lower esophagus. Try a shot of glucagon, which helps open up the lower esophageal sphincter, and sometimes it can slip into the stomach. So that way you can actually avert an endoscopy, because coins in the stomach rarely require removal. Greater than 95 to 98% of them will eventually pass, either right away or within the next few weeks. And so once a coin gets into the stomach, we don't necessarily have to rush to do an endoscopy or expose that patient to an invasive procedure. But if it remains stuck in the esophagus at any level, then certainly, removal by endoscopy is warranted. Next. Button battery, again, a very common ingestant because of their ubiquitous nature. The rule for the esophagus is emergent removal. So if there is a button battery in the esophagus, regardless of whether the patient is symptomatic or not, regardless of the location in proximal, mid, or distal esophagus, this needs to come out as soon as possible. If the button battery has already made it to the stomach or beyond, then certainly there are all these criteria. And again, the purpose of this presentation is not to walk through each of these criteria because we have a lot of ground to cover, but just to make you familiar that these algorithms are available. And then depending on the age of the child and the size of the battery, and whether or not anything else was co-ingested, you have these algorithms which will help you decide whether you can carefully wait and watch, or do you need to call your GI friend to come and remove this from the stomach. Okay, and I put the link in there for the interested reader. And then coming to some other scenarios, sharp objects usually have to be removed immediately. Again, objects that are rod shaped, if they are less than 5 centimeters, like nails and pins and pencils, they will actually spontaneously pass. So if there are no symptoms, then you can let them pass spontaneously. With magnets, if it's a single small magnet has already made it to the stomach, it can be allowed to pass spontaneously, but anything more than one or more than one magnet, or a magnet co-ingested with a metal or a metallic fragment, needs to be removed immediately. And yeah, so again, at this website, there are links that are definitely available for the reader, or for whoever is interested in looking at those detailed algorithms. I see there is a question here, so I'm going to take a pause. Yeah, so Asma says, a nail or pin sounds sharp. A great question, Asma. So yes, So nails and pins are sharp. But if it's, again, it all depends on what kind of nail or pin we are talking about. So certainly bigger ones with, sharper edges, do need to come out. But sometimes we have these little, very tiny pins with very, and it's actually been shown that when they do go through the GI tract, they actually lead through the non-pointed part, and so actually rarely perforate. So again, that can be a discussion there. Certainly, I would be more inclined to remove them, but I have had some parents where it has been like, it's really small, for example, especially, if it's like, like an ear pin or something like that. And the sharpness is, not that much, because they usually have the other pair of that earring, and they can feel it, and it usually leads through the non-sharp ends and rarely perforates. So some parents have then preferred to just let it pass spontaneously. But certainly larger ones, greater than 5 centimeters, should be removed. So to your point, sharpness by itself is not going to be enough in deciding whether or not it needs to be removed right away. There are other factors, including the location. Now, of course, sharp objects in the esophagus need to come out. It's usually in the stomach, which is a much more capacious organ, that we have some, flexibility based on the configuration and the size. I hope I answered your question there. Then coming to caustic ingestions, we all know that alkaline ingestions are more dangerous because they cause liquefactive necrosis, meaning deep ulceration, and there is risk for perforation, versus acidic ingestions, which tend to coagulate the tissue and actually form an eschar. Regardless, the general rule is, if you've had somebody with caustic ingestion, please make every effort to find out what that agent was. I've had people like bring the original bottle from home so that we can look at the ingredients, and we can, work with poison control to figure out what the exact pH might be. Although there are some, general themes on this slide for you to know which ones would be alkaline versus acidic. And then, if there are signs and symptoms like drooling or significant oral irritation, or we just don't know, we are not confident as to what the patient ingested, then usually an EGD is recommended so that we can do a direct observation of the upper GI tract. So yeah, these ones will definitely be referred to GI. I've had some cases of very dilute bleach ingestions that are not very powerful at all, are only mildly acidic with no significant oral irritation, and a completely asymptomatic, even smiling child that we have not done an endoscopy right away and just kept them under careful observation. But other than that, pretty much everybody else with a caustic ingestion usually warrants an urgent EGD. Yeah, and there's no proven role for these neutralizers like milk, that doesn't work. And then symptomatic child, of course, after we stabilize their airway, the ABCs, we do an early EGD as soon as available to assess the extent of damage. And if it is significantly damaged, then there is a role for putting an NG and initiating steroids until more definitive steps can be taken. I see a question here from Jordan. I imagine for caustic ingestion, we are sending to the ED first. Should we recommend NPO or drink water? Great question, Jordan. I would refrain from giving anything to drink, including water. I think keeping them NPO is best because, as I just mentioned, depending on what they ingested, how much of it, and how much damage you can see by an oral exam, they may be in for an urgent EGD, especially really caustic agents like some of these alkaline ones can cause deep ulceration and perforation in the esophagus within hours. So keeping the patient NPO is the best step because it helps the process of the EGD also, a preparation for the EGD. So I would not give them anything to drink, including water. And yes, you're right. These patients should be referred to the ED. If they're already in the ED, of course, call the GI on call. Thank you. So, okay, so I think we're now coming to some of these vignettes around hematochezia, I think. Yep. And so there are certain, scenarios that you can, see. The first one is a healthy, thriving young infant, usually in the first few weeks to months, with, blood stained or streaked stools plus minus mucus. So what's the most likely differential here? Cow's milk protein sensitivity, does occur in up to 10% of healthy babies. It's interesting to remember that, we associate anal fissure with constipation, and most of these babies, in fact, will have diarrhea, but it can be seen in 50% of, children with cow's milk protein sensitivity. So the point being that if you see a baby with hematochezia, this streaky typically, but the amounts can vary. I've seen, kids with like diaperfuls of blood, which was very scary. And you're thinking about Meckel's diverticulum, but the kid is like perfectly fine, hemodynamically stable, smiling, wanting to eat. I remember this one particular baby that I had that just rocked the whole emergency room, but every other evaluation came back negative. We switched the milk and to a hypoallergenic milk, and the baby did fine. So the amounts can vary, but most commonly, yes, it will be blood streaked stools. But point being that if you see an anal fissure, don't just assume that this is from constipation. It can be seen in half of babies with cow's milk protein sensitivity. So if the baby stools are soft, that's another clue for you to switch them to a hypoallergenic formula, since, we don't have any specific tests for cow's milk protein sensitivity. And then usually, and I know we're all probably familiar with this, I do not recommend switching them to a soy formula, because about 2/3 of babies will have, soy cross-reactivity also. So going to a hypoallergenic formula is the best, something like Alimentum or Nutramigen. And then sometimes if needed, even elemental formulas like Neocate and Elecare. Unless, of course, cost is a consideration. In some cases it is, and then we can try soy before going to hypoallergenic formulas, because they're definitely, way more costly than regular formulas. So I see a question from Sarah. When I'm helping a baby who is breastfeeding, I remind mom. Yes, Sarah, that is what I do. I recommend mom to avoid both milk and soy if possible. But again, these are very personalized discussions, and sometimes if they are not ready to do both, then we can definitely start with milk and then see what happens, and then add soy later if needed. So, but my initial recommendation is usually to eliminate is the right word, both milk and soy from her diet. I see a question from Autumn. Thank you, Olivia, or Jordan, for directing my attention to that question. It says, do you see a strong association of skin issues? No, I do not. It may or may not be there. And the reason being, skin issues, the classic IgE-mediated atopic skin conditions, are seen only in a fraction of kids with cow's milk protein sensitivity, because we now know that not all cases of cow's milk protein sensitivity are mediated by IgE mechanisms, which is why skin tests and RAS tests and many of these tests which are dependent on the IgE antibodies are actually pretty useless in the evaluation of cow's milk protein sensitivity. So skin issues may or may not be present. In my experience, I do not see them very commonly. But yeah, if I see them, that's additional information for me to think about. But no, it's not common, because not all of them are mediated by IgE. So you may not see that, the eczema and the skin issues associated with atopy. Yeah, thank you, Autumn. Okay, so we talked about all this, so we can move on. Next scenario is a 3-year-old, otherwise healthy child with bright red bloods in the stool. And I'm sorry, one second, please. Yeah, and a mass protruding from the bottom. Any takers for that? Feel free to put your ideas in the chat box. I'm following the chat box pretty closely. So this would be, so this is obviously, a painless mass protruding from the bottom. This is a happy, otherwise healthy child, but you're seeing all this blood. So this is a solitary juvenile rectal polyp. Very common in this age group, about 2%. So 2 out of 100 3-year-olds can have, such a presentation. And usually it is a solitary inflammatory polyp, meaning this is not linked to the juvenile polyposis syndrome, but we can talk about that as I go along. So basically the presentation is that of hematochezia. So the first and foremost question to ask is the consistency of the stool and whether there's associated rectal pain, because again, if there is rectal pain and hard stools and a mass coming out of the bottom, then it is more likely to be constipation with rectal prolapse, requires stool softening. And usually the prolapse resolves depending on the degree of prolapse. Now, higher grades of prolapse, of course, may require surgical treatment. Next slide, please. Versus the juvenile polyp that I was talking about, where the stools will be soft. And sometimes the bleeding is actually unrelated to having a bowel movement. And this can be, the one that I'm describing in an otherwise healthy child is a sporadic polyp, usually a single hamartomatous polyp found in the rectum of a young child. And in fact, many of the times it just auto amputates. Like I've had parents come to me with, oh, I could see this come out a few times and here it is in my hand now or in a jar. And it has no malignant potential. But of course, if sometimes I've felt them on a rectal exam and I've evaluated these kids in my office, and the treatment is polypectomy, because you do want to confirm and verify that this is in fact a hamartomatous polyp and not an adenomatous polyp, which has malignant potential, which is extremely uncommon in pediatrics. But one of the other reasons for doing a full colonoscopy in these children are you want to be sure that that's a single polyp that you see in the rectum, that as there aren't any other polyps higher up in the rest of their colon, because if you see that, and especially if it is greater than 5, then you have to start suspecting the possibility of juvenile polyposis syndrome, which is a completely different ball game, where you're talking about a genetic disorder which will make that child prone to developing hundreds and hundreds of polyps that have a malignant potential, not only a colonic malignancy but also extra intestinal malignancies. And so those patients are typically then followed in specialized polyposis centers because they need regular surveillance, and most of them will undergo a prophylactic colectomy between 15 and 20 years of age. So that's a different ball game. Again, that's an autosomal dominant disorder. So many times there will be a family history, but I will also remind all my friends here, remember, you could be at a particular generation the starter point for any autosomal dominant disorder. So just because you don't have a history prior to your generation of an autosomal dominant disorder doesn't mean that that can't exist, because the mutation can start at your point also, at your generational level also. Okay, next. This is about JPS, the juvenile polyposis syndrome. This is where the number 5 comes from. So greater than 5 juvenile polyps in the colon really should alert you to the possibility of JPS, and there's genetic testing available for that if there is not already a known family history. Next. Okay. So now we're coming to another presentation. This is a 2-year-old with profuse, painless, brick red colored or maroon stools. And these, these expressions or these words or phrases that I've underlined are like your key words or phrases. Sometimes we see them on boards. So it is very helpful for residents or people here who may be, recertifying, who is tachycardic on exam and has anemia. What might this be? So there are definitely some clues. There is an age. This is a younger child, and the degree of bleeding, it is profuse, it is painless, so unlikely to be from constipation or straining or anal fissure. And there is some hemodynamic implications here. This patient is tachycardic and has anemia, suggesting that they have lost a hemodynamically significant amount of blood. Next slide, please. Meckel's diverticulum is what we are dealing with here, and we are probably all familiar with the rule of twos. So usually a 2-year-old child, with symptomatic bleeding with or without abdominal pain. And the diverticulum itself is about 2 centimeters long. It is 2 feet from the IC valve and typically present on the anti-mesenteric border. And when we have such a presentation, the test of choice is a Meckel scan. We usually prime them with an H2 blocker to increase the sensitivity of the scan. And that's how we make this diagnosis. And if we find it, the treatment is surgical. Next slide, please. As I said, it is a nuclear medicine scan and, fairly high sensitivity and very specific. And of course, we have to stabilize the patient and then pursue the testing. Next. So next presentation is a 13-year-old with progressively worsening diarrhea with blood, abdominal pain, fecal urgency, reduced appetite, and weight loss. So again, some clues here. This is a child, an adolescent, and this is progressively worsening, telling us that this has been going on for a while. And there is pain, fecal urgency, reduced appetite, and weight loss. So the possible differentials here are inflammatory bowel disease or a chronic invasive GI infection. Next slide, please. But as I just said, IBD, either Crohn's or ulcerative colitis or indeterminate colitis, is the most likely etiology here. But some infections like Yersinia may also mimic Crohn's disease. Next slide. And then there are some extraintestinal manifestations. Overall, they are rare in pediatrics. I can't say that I've diagnosed IBD in my patients mainly because of extraintestinal manifestations, but they can occur. And these can be in the form of, characteristic skin rashes like erythema nodosum, which are basically patches of paniculitis, painful nodules, usually on the shins, can be seen in about 10% of Crohn's disease patients. CD stands for Crohn's disease here. And then pyoderma gangrenosum, which are these painful violaceous ulcers, again, usually found in the lower limbs. Then there is an association between oxalate, urinary crystals, and renal stones in Crohn's disease patients. But most of the diagnosis, pediatric diagnosis, is actually made because of GI symptoms. Next slide. Next, and again, I'm not going into the details of treatment of IBD for today's presentation. This is just, to discuss some common scenarios that you may see in your office. So this is a child with sudden onset of fever, crampy abdominal pain, bloody diarrhea with mucus, also known as dysentery. And usually there'll be some clue pointing to an infectious exposure. So this is shigellosis, the catchword here is, or the key phrase here is, a daycare outbreak. And there are some extraintestinal manifestations associated with it, like seizures in young children and non-suppurative arthritis. Next. Salmonellosis, non-typhoidal, can also have a similar presentation. And again, there may be some of these, clues. Do not routinely require antibiotics. But in some cases, like younger infants, or if you're immunosuppressed, or cancer patients or other chronic inflammatory diseases, you may consider treating. Hello? Can you hear me?
Yeah, sorry about that. The feed cut in a little bit in and out for a bit, but I think we're back on.
Okay, I'm sorry. I don't know how much people heard me, but yeah, we're talking about salmonellosis. And I have a question.
Yeah. Dr. Galati, I think your feed's going in a bit and out. I don't know if anybody wants to leave in the chat, if it's just on our end or if everybody's experiencing that, but maybe try turning off your video. Sometimes that will help with the feed.
Somebody else's too. A message. But if she's frozen, she's not going to see the feed. I just told everybody.
Hi, can you hear me?
Yes, I think we're back again.
About that. Yeah, sorry about this inconvenience. Yeah, but yeah, so coming back.
Dr. Galati, you paused again. If you want to maybe try turning off your video, but leaving the sound on, that might help with the feed.
Cannot, and I will definitely support that.
Okay, well, you need to tell her that nobody heard.
Dr. Galati, that last bit, I think, cut out again. If you wanted to just recap that quickly. Sorry about that. And there's also a question in the chat for you when you have a second.
Hello, can you hear me now? Shall I keep going?
Yes, I think we're back, hopefully. Fingers crossed. Go ahead.
Okay, do you think turning off the video might be helpful? Is that something?
Yeah, I think sometimes that helps if just to, not overload the feed. So
Sure. I will turn off the video then, for Hello, can you hear me?
I can hear you now.
Okay, yeah, no, I haven't turned mute or anything. Just took myself off the video because someone suggested that might help with the audio.
if we're still having some issues, I can also try to send you just a number to call in via the phone. So if you want to try going again, and if not, I'll give you a heads up and I'll try to just send you a number to dial in.
Hello, can you hear me now?
Yes, we can. Let's go. Let's try again.
Okay. So next slide, please.
I'm sorry, everyone. We're just going to take a quick couple minute break. We're going to try to get this audio back up and running.
Hello? Hello?
Hello. All right.
Hi.
Hello.
I'm sorry, I don't know what happened. I just decided to, log out and come back again because can you hear me now?
I can. And that, fingers crossed, it's staying this time.
Okay, great. Yeah. So we were talking about some bacterial causes of dysentery, and in that, the fact that most of them actually do not warrant treatment, but some do. And yeah, that's what we were talking about, if there was a specific question about that. And then we're all familiar with Reiter's syndrome, where in relation to infection with Salmonella, Shigella, and Campylobacter, we can develop, arthritis, which is rheumatoid factor negative, but HLA-B27 positive. And then one point that I wanted to say here is that let's not forget that even viral causes of gastroenteritis can present with bloody diarrhea. It doesn't always have to be bacterial. And I know that most of us, do check for infectious organisms in the setting of bloody diarrhea. Okay, next slide. Next scenario is a 4-year-old boy who develops colicky abdominal pain, vomiting, hematochezia, and shortly afterwards, these petechiae and macular rash on the buttocks and extensor surfaces of arms and legs. We're dealing with HSP. Next slide. Which is a kind of small to medium vessel vasculitis. The GI tract is affected in about 3/4 of the patients. And some of the manifestations can be related to hemorrhage in the bowel wall. So that's what can cause the blood in the stool. Colicky abdominal pain, intussusception can be a presentation. There can be an actual perforation. And then some extra intestinal manifestations like hydrops of the gallbladder and pancreatitis. And then treatment is steroids. Okay, I see there's a question. So question is, antibiotics treatment for hematochezia, does the release of bacterial toxin from the Yes, Jordan, that can happen. And that is what I was referring to. I don't think we can generalize it by saying antibiotics for hematochezia. It is important to identify the organism. So as I said, it varies from organism to organism. For example, if we find Shigella is the underlying cause of the dysentery, then yes, we will treat that. Whereas E. coli and certain types of Salmonella, if they are the underlying cause of hematochezia or dysentery, then we will not use antibiotics. So it depends on which organism is identified as the cause of dysentery. I hope I answered your question. Okay, next slide. The next scenario is a 3-year-old who presents to the ED with mild jaundice, pallor, lethargy, and dehydration. And the labs reveal hemoglobin of 12, bilirubin of 3.5, a white cell count of 15K, low platelets, and elevated renal function tests, as you can see, BUN 42 and creatinine 2.4. And a few days ago, he had developed an acute onset febrile illness, vomiting, and bloody diarrhea. So this is one of those scenarios we're dealing with HUS, or hemolytic uremic syndrome. Next slide. Which is a microangiopathic hemolytic anemia. And this particular strain of E. coli, the ETEC, which is usually acquired from meat and causes this bloody diarrhea, is the one that we don't want to use antibiotics. This is the answer to your question, Jordan. This is one of those bacteria that we will not use antibiotics here because it can increase the chances of development of HUS, or hemolytic uremic syndrome, which can be life-threatening. So in these cases, supportive management is recommended. And of course, antibiotics are contraindicated. But this is not the only bacteria. As I said, most cases of Salmonella and even Yersinia and Campylobacter, we will not treat with antibiotics. Next slide. Next is, I think we're shifting gears here a little bit to just causes of diarrhea, not necessarily with blood. This is a 2-year-old, otherwise healthy child with normal growth parameters. So this tells us that there is, really no effect on the child's weight or height. So malabsorption would be unlikely here, but with multiple loose stools per day and noticeable undigested food materials. Any takers for that one? What might we be dealing with here? This is toddler's diarrhea, or benign diarrhea of infancy. Next slide. And this is a benign cause of diarrhea. And these are not babies who are suffering from any malabsorption or any nutritional deficiencies. And it is common in kids like younger than 4 years, and felt to be because of a combination of, just the osmotic effects of certain foods in our diet, like sorbitol and fructose in juices, but sometimes even, kids who drink a lot, even if it's just water or their milk, and not have enough fiber in their diet, and some limited capacity of the colon to reabsorb fluid. It is self-limited. We usually recommend dietary treatment, like limiting juices, fluids in general, and increasing some fiber and fat in diet, and that usually takes care of it. But it's benign, so mostly reassurance and dietary management is what is recommended. Next slide. And then some other chronic diarrhea scenarios, infectious, that you can see that where there can be some overlap with infections will be chronic giardiasis. You may see failure to thrive and steatorrhea there. In immunocompromised host settings, cryptosporidium can cause chronic cholera-like diarrhea. And then there is a syndrome called the pseudoappendicular syndrome, which can mimic terminal ileitis, appendicitis, or Crohn's ileitis by Yersinia. And as I had mentioned earlier, we don't usually treat Yersinia. It is self-limited, but in special populations like younger kids or immunocompromised individuals or individuals on, with just chronic debilities, we may decide to treat it. And then again, this can be associated with syndromes like Reiter's, Miller-Fisher, and Guillain-Barré syndrome. Yersinia and Campylobacter both can be associated with these extraintestinal syndromes. Next. Then bloody diarrhea in the context of recent antibiotic use, C. diff, we all know to check for it. And I would like to point out here, though, that the epidemiology of C. diff has evolved. It is not like a hospital acquired infection anymore, that it can be seen even in the community. And the history of antibiotic use may not be that recent also. So if it's there, surely check for C. diff, but keep that in your mind. Even if the history of antibiotic use is, from a few months ago. I've definitely seen kids in my practice with C. diff from antibiotic use up to 6 months ago. And then I apologize, the treatment of choice now is not Flagyl, but vancomycin. So I just needed to update that. But yeah, so the treatment of choice is vancomycin. We don't use Flagyl as first-line treatment for C. diff anymore. So apologize for that mistake there. Next is protracted diarrhea, flatulence, weight loss in the setting of immunosuppression or exposure to contaminated water. Think about giardiasis. As I mentioned, giardia, which is a parasite, can induce subtotal villus atrophy, and it can present the presentation can be similar to that of celiac disease, where there is villus damage, and hence you can have all these malabsorption problems. So think about giardia in the right setting. Next slide. So next scenario is a 7-month-old with poor growth, irritability, weeping rashes in the perioral and perineum, and chronic diarrhea and alopecia. We're dealing with acrodermatitis enteropathica. Next slide. It is either primary, which is related to certain mutations leading to zinc deficiency, and secondary to intestinal damage, secondary to Crohn's disease, celiac, cystic fibrosis, chronic liver disease. So certain other chronic inflammatory disorders can be associated with secondary acrodermatitis enteropathica. One of the classic lab findings here will be a low alkaline phosphatase. Alkaline phosphatase is an enzyme that requires zinc as a cofactor. So that may be a clue that we're dealing with a zinc deficiency, either primary or secondary to intestinal and extraintestinal disease. Treatment, of course, is zinc supplementation. Next slide. Next scenario is this 15-month-old Caucasian infant with poor weight gain, loose stools, abdominal distension, irritability, thin extremities with loss of subcutaneous fat. This is your classic presentation for celiac disease, which we know is an autoimmune disease triggered by gluten in our diet. And the HLA DQ2 and DQ8 are very, very prevalent in individuals with celiac disease. Greater than 95% of individuals with celiac disease will carry these haplotypes. And we screen using the tissue transglutaminase IgA, which is very sensitive and specific for that. And we confirm with an endoscopy. Now, there is some controversy in the area of invasive diagnosis of celiac disease. So our European friends in the European world have come up with some guidelines which are not yet widely adopted here. I mean, we're all aware of them, but those guidelines suggest that really elevated levels, greater than 10 times upper limit of normal TTG IgA levels, which is tissue transglutaminase IgA levels, with the right clinical setting, you can potentially choose not to do an endoscopy and treat them as celiac patients. So again, there is this risk stratification based on the level of elevation of tissue transglutaminase, of course, in the proper clinical setting. I can't say that this is widely adopted here in North America. Most of us and most of my colleagues still do a full endoscopy with biopsies and confirm the classic histopathologic features of celiac before committing someone to a lifelong gluten eliminated diet or gluten-free diet. Okay. Next. Some extraintestinal manifestations of celiac, again, to bring home the point that they are there, but not commonly seen. I can't say that I see a lot of this in my pediatric patients, but just for you to be aware that some patients may present with atypical or extraintestinal manifestations that may give you a hint to look for celiac disease. Among those, definitely refractory iron deficiency anemia. There are two other gastrointestinal disorders, of course, other than nutritional anemia, which, however, should not be refractory to oral iron. So whenever you see this clinical scenario where you are dealing with a child who has refractory to oral iron supplementation anemia, you should think about celiac, because there is this villus damage which prevents iron absorption in the proximal small intestine. That's where most of the iron is absorbed. And then we have H. pylori gastritis, or Helicobacter pylori gastritis can cause refractory iron deficiency anemia. And third will be Crohn's disease, especially affecting the proximal small bowel. Then short stature and dental enamel hypoplasia. I would say I've seen some cases where celiac can be diagnosed based on some extraintestinal manifestations, because not all children with celiac will have GI manifestations. I see a comment here, even Euro guidelines suggest to send all suspected. That is true, that is true. When I was talking about the Euro guidelines, this was not about whether they need to be referred to GI or not. It is absolutely true that anyone that you suspect celiac should be referred to GI. And then the GI physician, based on how comfortable they are using these guidelines, may elect to do or not do an endoscopy, or at least have that discussion with the family. So it was more related to the role of the gastroenterologist and whether they would, what kind of discussion they could have with the parent. So some of our European gastroenterologists with really high TTG, IgA levels, and the characteristic clinical findings of celiac can have that discussion with parents to forego an endoscopy, an invasive procedure, which, although overall very safe, still, is not completely risk-free, to not have an endoscopy and treat these children as celiac patients without the endoscopy. Next slide, please. And then some celiac disease associations. It's more prevalent in children with Down syndrome. In fact, there are some recommendations in the Down's guidelines, management guidelines, to evaluate for celiac disease at periodic intervals, even without weight loss, even without any characteristic evidence of celiac, because referring to that celiac iceberg phenomenon, majority of patients who have celiac will not have the classic GI symptoms. Yet, if that intestinal inflammation continues, there can be other consequences, downstream for them, like nutritional deficiencies, anemia, poor bone health, and the real risk of developing a small intestinal lymphoma in their lifetime. Then Turner's, Williams, selective IgA deficiency, and then some other autoimmune diseases, particularly type 1 diabetes. I do have quite a few type 1 diabetes patients in my practice where the endocrinologist, at periodic intervals checks celiac, and some of them came back with elevated TTG IgAs that were referred to me, and I diagnosed them with celiac, even with no classic GI symptoms of celiac disease. And they are on a gluten-free diet, because the gluten-free diet is important, not necessarily just for the GI symptoms, but for preventing some of the lifelong complications that can happen with undiagnosed celiac and persistent intestinal inflammation related to exposure of gluten. Next slide. We're shifting gears here a little bit. So the next few scenarios will deal with hematemesis, that is vomiting of blood. Usually, a manifestation of an upper GI bleed, so something coming from the esophagus or the stomach, or usually even, proximal small intestine up until the ligament of Treitz. If it is brisk, it can, even lead to hematochezia, which is like bright red blood that just didn't have the time to get converted into acid hematin by the acid in the stomach, but mostly presents as melena, which is the more hematinized version because of the acid. And again, if you're seeing a kid with hematemesis, the degree of hematemesis can vary from like a small spit up of blood or, blood streak spit up to like, vomiting cupfuls of blood. And so depending on that, obviously, stabilizing the patient is important and triaging them based on their, initial vitals and, all those initial evaluation, right? And then again, I doubt that many of us would be doing this in our offices. Hopefully by this time, the patient, if it is deemed to be a hemodynamically significant bleed, would be in an appropriate setting, an ED, ER, or in the ICU. And, you would undertake the next few steps like, putting an NG, doing a lavage to determine whether active bleeding is going on or if it has ceased, because that helps you decide how soon you need to call your gastroenterologist. Next slide, please. And as I said, further steps will really be based on the color of the lavage fluid. Many times the bleeding has happened and stopped. So in many cases of, for example, erosive esophagitis or erosive gastritis bleeds, not so much with your esophageal varices, those really continue because they're large volume and more significant. But in some of the erosive upper GI diseases, the bleed has usually happened. By the time the patient presents to you, new lavage, the fluid may be clear or may just have some old blood, which gives you some time and tells you that this is not necessarily an emergent phenomenon. I mean, you'll still call your GI and get them involved, and then they will determine how soon and when they need to do an endoscopy for further diagnosis, but that would be helpful. The lavage fluid would help you determine that. But then again, if the bleeding is bright red and ongoing, then you stabilize, you start your octreotide, call your gastroenterologist and prepare for an emergent endoscopy. Whereas coffee grounds with clearing fluid usually implies that active bleeding has stopped, so there is no need for emergent endoscopy. Next slide. And then some scenarios in which you may see this. I know Sarah talked about pill esophagitis. So your teenagers with acne on tetracyclines typically complain of odynophagia, but every now and then, if the irritation is significant, they can actually present with some hematemesis. It can't say that it would be high volume by any means, but certainly can happen. So getting that history is important. And then other corrosive medications, I've seen it with NSAIDs and then alendronate. I can't say I've seen anybody with alendronate present, but definitely NSAIDs. And then, of course, if you're having a large volume hematemesis, stabilized your patient, you're doing your physical exam, you find this huge spleen, you may or may not find jaundice, some underlying, liver disease, right? I mean, occasionally there may be a patient who may present to you with, a previously undiagnosed liver problem and hematemesis, although most of these patients are known chronic liver disease patients with evidence of portal hypertension and are just, at risk for developing hematemesis from esophageal varices. Next slide. Just a word about NSAID-induced GI injury. I mean, it is quite common. Again, ranges in severity from just, stomach pain to erosion in the esophagus and the stomach leading to bleeding. And we usually, recommend limiting these medicines as much as possible or trying some of the selective, COX inhibitor medications. But if and when it happens, we use, after we've controlled the bleed, we will typically put them on a PPI like omeprazole or lansoprazole. And then sometimes there's a role for misoprostol also. Next slide. Then some other scenarios, violent retching and purging in the context of even acute illness, a Mallory-Weiss tear, usually present with, some streaks of blood or maybe even a little bit more than that, but then it stops, right? And so it doesn't continue. These patients don't complain of continuing chest pain or have no melena or hemodynamically stable. Most of the time, it's a clinical diagnosis that in the right setting you can make comfortably and does not usually warrant an endoscopy. Another setting would be, risk of H. pylori gastritis or ulcer disease. Again, not very common in the general population, but there are certainly certain high-risk individuals, especially, if there are, concerns around sanitation, low socioeconomic status, immigrant populations. There are parts of the world, especially in many developing countries, where H. pylori is very prevalent. So certainly, I have seen a lot of this in some of our refugee children that I see in my clinic. So, keeping in mind that they're definitely higher risk than the general population. And if you suspect H. pylori, we really recommend a referral to GI. We discourage using antibiotics without a confirmed diagnosis of H. pylori. I've seen a lot of children who have been treated with the triple regimen and sometimes the quadruple regimen based on antibody tests, and that is strongly discouraged. Because we really want to confirm the diagnosis. We want to know the extent and the spectrum of disease, because it ranges from gastritis to ulcer to early carcinoma, which is very rare in pediatrics, but can happen. So my advice here, or my suggestion or my recommendation would be that if you suspect H. pylori, either through blood work, but the better would be the stool antigen test, because that tells us about active infection versus just remote exposure to H. pylori, then please refer them to your GI colleagues for a full evaluation before treating them with antibiotics. Next slide. Next slide, please. Okay, so the next scenario.
I just wanted to give you a brief heads up. We're kind of about 15-minute mark left, so just want to make sure we have time to cover everything you wanted to.
Absolutely, yeah. And so the next scenario is a 2-year-old male infant with poor weight gain, loose, greasy, bulky, foul-smelling stool. Can move the slide, please. So here we are dealing with the greasy, bulky, foul-smelling stool is telling you about excessive fat in the stool, so steatorrhea, usually from pancreatic insufficiency, and there are various causes of it, and you can go through those, at your convenience. I understand these slides will be shared with you, but for the interest of time, broadly, steatorrhea is caused by pancreatic insufficiency or inflammatory intestinal mucosal disease. Can move on. And these are some scenarios of pancreatic insufficiency, Shwachman-Diamond syndrome. Next slide. Testing for it, other, extraintestinal manifestations. We can move on. And then some other steatorrhea syndromes there. Johansson-Blizzard. Next, please. Pearson's marrow pancreas syndrome, and we have a Jeune syndrome. You can move to the next slide. And then really coming to the diagnosis. So the gold standard indirect test is that most of us should be able to do in our clinics, or in at least a GI clinic, will be a 72-hour fecal fat test. And then we calculate the coefficient of fecal fat excretion or absorption, whichever you want to. And then there are some values there that will tell you whether, based on the fat that you've ingested, and this is done in a pretty standard manner. So we usually work with a nutritionist to do it, because it is relative to the amount of fat ingested over those 72 hours. So that would be your indirect test. Now, a quick spot test that you can do in your office if you're suspecting pancreatic insufficiency would be a fecal elastase test. It's a fairly sensitive test for at least moderate to high-grade pancreatic insufficiency. And you can get started there and then refer these patients to GI for further workup if that comes back low. And then, of course, the gold standard test, which is usually important in research settings or applicable there, is the CCK secretin stimulation test. We don't do that in our clinic. Next slide. And if you diagnose somebody with steatorrhea, again, depending on what the final diagnosis is, of course, there'll be management based on that. But for the pancreatic insufficiency part, we usually, give pancreatic enzyme replacements. I mean, those of you who take care of, kids with cystic fibrosis, probably have, experienced or seen your kids on pancreatic enzyme replacement therapies. Fibrosing colonopathy is a side effect that we need to be aware of. It's rare. I have not seen that happen that much. And that is why, to prevent that, most of these patients are also on some kind of gastric acid suppression. So Pepcid or even PPIs like omeprazole. Next slide. Then, of course, some of you may see kids who fit the clinical profile of recurrent pancreatitis, meaning just repeated episodes. Most kids in their lifetime may have one episode of acute idiopathic pancreatitis, presumed viral. That is the most common. But there are some kids who may have recurrent episodes of pancreatitis, which is, 2 or more. And then you start thinking about the possibility of some of these disorders, like, heterozygous mutations in the CFTR gene and cystic fibrosis. Then there is something called hereditary pancreatitis related to mutations in genes that code for trypsin inhibitor or trypsinogen gene, the PRES and the SPINK mutations. Then autoimmune pancreatitis, and then also suspect anatomical malformation. So most of these patients in their workup will also probably have an MRCP to look at the ductal pathology and the hepatobiliary tract pathology in a little in a little bit more detail. Next slide. Some rare causes of recurrent pancreatitis. I know, we check for triglycerides, calcium, and of course, gallstones, some organic acidemia, some metabolic disorders can also cause recurrent pancreatitis. And again, based on most of the times when you're seeing such a patient, you would probably have referred them to GI. And then depending on what the GI feels, they may be co-managing these patients with a metabolic expert if there is no anatomical cause or some of these genetic causes come back negative. Next. Shifting gears quickly to jaundice and neonatal cholestasis. We all know physiologic jaundice, and we all know that direct hyperbilirubinemia at any point is always pathological. And then persistent jaundice beyond 14 days. And sometimes even, I know that, especially if there is direct hyperbilirubinemia that you've diagnosed even younger than 14 days, it warrants immediate referral, because the number one etiology that we are trying to rule out, of course, in a kid who otherwise appears to be normal and does not, is not acting like a metabolic kid, or who's really sick, or recurrent vomiting, or any of those issues with him, is biliary atresia, because biliary atresia is a treatable cause of neonatal cholestasis. Not all causes of neonatal cholestasis are treatable. The differential is huge, ranging from anatomical causes like biliary atresia, choledochal cysts, to metabolic causes, to infectious causes, especially intrauterine infections, to hematological causes. There is just broad differential, but again, our focus should be to go after the treatable causes first. Next. So biliary atresia, we know the common one is the isolated biliary atresia, but then there is also, the embryonal form, where there are other, also called the BASM, where there are other abnormalities. And those patients, or those children, tend to fare poorer because of the associated congenital malformations, other congenital malformations. Next. And typically, again, these kids will present with progressive jaundice. They may or may not have acolic stools in the first few weeks of life. They will gain weight poorly because of a lot of fat malabsorption. They will have fat-soluble vitamin deficiencies. And, unless we diagnose this in a timely manner, where we all are familiar, we ideally want to make this diagnosis as quickly as possible, so that the palliative surgery, which is Kasai, can be done as quickly as possible to reestablish bile flow and prevent some of the fibrosis. Although 80% of those kids also eventually at some point will need a liver transplant, but we still want to establish that biliary drainage through a Kasai portoenterostomy as quickly as possible, ideally in the first 8 weeks. So that's the sort of rush factor there, because it has been shown that the longer or the more delayed the diagnosis is, the poorer is the prognosis for even the Kasai. And of course, these kids end up then requiring liver transplant sooner. The initial test of choice would be a HIDA scan. You can also do an ultrasound, and you may see, the triangular cord sign. But again, a HIDA scan will really, if it does not show excretion, that is highly, highly suspicious for biliary atresia. And the final confirmatory test, of course, would be an intraoperative cholangiogram. Next slide, please. Yeah, so if suspicion still persists in IOC, and then usually what is done, like what happens in clinical practice is if you reach the point where you're considering an intraoperative cholangiogram, then they also combine it with a liver biopsy. And if they establish the diagnosis of biliary atresia, the treatment will be a Kasai portoenterostomy. Next. We can immediately reestablish bile flow. And then these are some statistics out there that despite doing a Kasai, as I told you, 80% will eventually still need a liver transplant, but at different points in their life, they may be older and the prognosis for a liver transplant is much better with increasing age as opposed to, a newborn or an infant. Next slide. And then other neonatal cholestatic diseases that we just need to be aware of. Alpha-1 antitrypsin deficiency is the most common metabolic cause. So this is an easy, blood test that you can send, even as you're evaluating for other causes of neonatal cholestasis. We can't affect the course of alpha-1 antitrypsin because, unlike the lung part of the disease, which develops in older individuals, we don't have much for the liver. But at least, again, it's an established diagnosis, and then you follow these patients to the point where, their liver develops chronic liver disease and they become candidates for liver transplant, which again varies. I've had 4-year-olds with alpha-1 antitrypsin that I've referred for liver transplants. And then I've had teenagers, or even young adults who, are still with their native livers doing just fine. Next. I think we'll move on. This is more acute setting, probably something that you will see in the newborn nursery or in the NICU, probably not that applicable for primary care. So we will move on some of these slides, but the interested reader can always refer to them. Next slide. So I'll skip over some of these slides. We've talked about other causes of neonatal cholestasis. I know we are running out of time and I want to leave enough time for questions. I think we will leave out the chronic hepatitis part. This is more, infectious disease related. So we can skip over the next few slides. And I do want to come to the slides that talk about Hirschsprung's disease. So we can keep moving, Olivia. Yeah, so we talked about circling back after all, sort of going through the entire GI tract and even touching a little bit upon the liver, coming back again to, constipation that Sarah started out with. Majority of, otherwise healthy children will have functional constipation. From a specialist perspective, really Hirschsprung's disease is rare. Usually will present in the first few days or weeks of life with lower intestinal obstruction. So something really hard to miss. And if you suspect that, definitely, refer them to GI. But even before that, you can do some tests, like you could do a barium enema to look at the rectosigmoid ratio that can give you some hints about whether or not Hirschsprung's is likely. But really, the next step is then, depending on the presentation, right? If it is really acute, we may even just be calling the surgeons right away to relieve the intestinal obstruction. And then they do biopsies and find that there are no ganglion cells. So again, it's a spectrum of severity, and depending on the severity with which a patient presents to you, you may be at different stages with them and can do some of these, tests like barium enema if you feel comfortable, or refer them to GI. And of course, they can take it from there. There is something called, short segment or ultra short segment Hirschsprung's disease. It's a controversial diagnosis. Certainly, if you suspect that, manometry would be helpful. You can sometimes refer, and these are usually older patients. They will not necessarily present with, intestinal obstruction, unlike full-blown Hirschsprung's. But these are your more refractory constipation or difficult to treat constipation that you could consider a barium enema to look at the rectosigmoid ratio to get some initial information gathered for the specialist, and or refer them for manometry, where we will not see the rares. And then again, confirmation will still be looking at rectal biopsy specimens to document the absence of ganglion cells. Next slide, please. Next slide. I think, yeah, and then there are some association of Hirschsprung's disease. I'm sure we're all familiar with these. And then of course the diagnosis and then the treatment is surgical. I think I will stop here just to leave a few minutes if, folks have any questions about for me or for Sarah. I know that there was just a lot. Thank you for your appreciation. I know there was just a lot of material to cover. Try to do it as comprehensively, and some of this, may be applicable to you, and some, just good to know, and so that we can make those appropriate referrals. But really, functional constipation, very common. A bowel clean out is absolutely necessary if you have someone with fecal impaction. Please, do not start maintenance treatment on someone with fecal impaction, because we can make their overflow worse. So that bowel clean out is important to acutely decompress the intestine, and then we start them on their maintenance treatment. That's like the most important point for functional constipation. And then, yes, it does take a long time, sometimes, 6 months to a year or two. And the general wisdom is that if you diagnose functional constipation in a kid who is in the process of potty training, that we let that process complete and then wean them off the medication, because we don't want painful stools or, hard to pass stools interfere with their potty training process, because it'll, reinforce the stool withholding behavior, which is what we're trying to overcome when we are potty training these kids.
Dr. Gulati, would you take a minute to maybe just talk about the follow-up process too? We've referred now to a gastroenterologist, and if we could, and I appreciate everybody hanging on here just for a few more minutes, but I think it's important to go over that, because it always, should they come back? Should we continue to follow? How should we continue to communicate with you? So thank you for that.
Yeah. So I think, great question, Sarah. And to your point, because the spectrum of possibilities is so wide, right? Ranging from functional disorders to organic disorders like inflammatory bowel disease and all, the recommendation will vary a little bit based on the diagnosis. But it is safe to say that most functional disorders like functional constipation or functional reflux or irritable bowel syndrome, or functional abdominal pain, even cyclical vomiting, abdominal migraines, those patients, once you've had your consultant's report and chatted or interacted, and you kind of know that this is what we're dealing with and nothing else, at least not at this point, I think those are very appropriate patients to continue to follow up in your practice, right? Yet remaining vigilant about the fact that if anything changes, and this is what I tell a lot of my patients, at this time, this is my best impression. And I always leave the door open to, if anything changes, or if you start noticing any of these red flag symptoms, just for example, if I see a patient with what I think at the time is, for the most part, your garden variety gastroesophageal reflux disease, which I feel very comfortable treating with an acid reducing medicine for a few weeks, lifestyle modification, stress management, whatever may apply to that individual patient, that is what I will do. But then I'll also alert them or educate them about what else to look out for. So for example, difficulty swallowing or persistent chest pain, or vomiting blood, if any of those start happening, certainly we need to reevaluate, right? Because not every GERD will need an endoscopy right away, but certainly if the symptoms evolve, open to reevaluation. And so that's what I would say for that relation to the follow-up with the PCPs, to have that communication open, that yes, I'm sending this patient back to you. This is what I think is going on. And I feel perfectly comfortable, as long as you're comfortable, within these parameters to follow this patient. And if anything changes, happy to send them back to me. Versus, I think for the most part, if there is somebody that I diagnose with inflammatory bowel disease like Crohn's or colitis, those are the ones that are going to be becoming my patients for the most part, although I've had some, amazing PCPs who've just asked me, okay, sometimes it may happen that, you're out of town or whatever, and they may come to our clinic. Is it okay to start steroids? If there's an acute flare, what are the parameters? So, I've had those also, those kind of, relationships also, where PCPs are very, open to and willing to, within parameters, treat even acute flares of IBD, for example. Right. So I think I definitely encourage follow-up, because I do feel as a consultant, I do have limited availability. Right. And so I definitely support sending these patients back to the PCPs and establishing that relationship with primary care for them to, feel very comfortable taking care of acute flares, or, what to look out for, and, when to re-refer these patients back to me.
Would you mind, there was a question in the comment, would you mind going over what your regimen is to do a clean out? So what I do is, so we've come up with this at Metro, we've come up with this very nice, it's very evidence-based, weight and age-based, and I'm happy to, share that through Ohio AAP, and you can share it with all our, our attendees here today, regimen, which we use for our, colonoscopy cleanouts, for example. We use similar ones for our constipation. So it is usually heavily dependent on Miralax, so polyethylene glycol, certain capfuls, and certain amounts of, Gatorade and all, that is all very evidence-based. But say for an average teenager, about 15 capfuls of Miralax in about 50 ounces of Gatorade, typically is what we give to an average teenager to disimpact them from above. But sometimes, again, if there is a big fecal impaction, then we like to first get that out by using an enema, so that, when they start drinking all this liquid from above, their bellies don't get bloated up. So it's usually a combination of rectal therapy if needed, based on either an exam or a radiograph, followed by, Miralax-based treatment or polyethylene glycol-based treatment. And then I also add a stimulant like either Dulcolax or Senna to the regimen. So it's a very stepwise process, which is very similar to what we do for our colonoscopy cleanouts. And remembering that sometimes, based on the degree of impaction, you may have to repeat a clean out once or twice if you're heavily impacted. But as I said, not everybody needs 15 capfuls. So for example, just off the top of my head, a 3 or 4-year-old would probably need 3 or 4 capfuls of Miralax. And I try to minimize the volume that they have to drink. So my ratio is usually a capful of Miralax to 4 ounces of liquid. And that's perfectly safe. There are studies on this, which have reported no electrolyte abnormalities and better tolerance than the 1:8 ratio that is, popularly available or talked about. And I see one more question, the 3 causes of, so resistant iron deficiency, Nicola, celiac, Crohn's, and H. pylori gastritis, Helicobacter pylori gastritis. These are 3 differentials or 3 GI related possibilities. Now, of course, resistant iron deficiency anemia can be from non-GI related causes also, but I was talking about GI related causes. These are the 3 that I would think about. Yeah, thank you. Those are great questions. Really enjoyed answering all of them.
All right, thank you so much, Dr. Adams and Dr. Gulati. That was great. I think we covered all the questions, and we're just about over. So we appreciate everybody joining us today. The links for the CME and the slides are in the chat box, and we'll also be sending a follow-up email. And definitely, if you have any other questions, you can send us our way too, and we'll make sure we get to Dr. Gulati and Dr. Adams for you. Thank you, everyone.
Thank you for the opportunity. It was fun being here, and I'm happy to, share the bowel clean out regimen if needed. Like, we can talk about that, and I'm happy to send that materials to you so that you can share with the audience.